Hello, I'm Dr. Ayub. Today I am here to discuss about attention deficit hyperactive disorder. This is also known as hyperkinetic disorder in ICD-10, while in DSM-5 it is known as ADHD. If we see the presenting problem in ADHD, these child present with hyperactivity, inattention, and impulsivity. If we see in more detail, the hyperactivity can be in the form of restlessness, fidgetiness, or this child may be or seems like full of energy, they are running all the time, they are noisy, continuously making chatters, interrupting, and not able to play quietly. The hyperactivity in this child is severe, persistent, and sustained. If we see inattention in this child, it may present in the form of forgetfulness, being distracted, they are not able to listen, they are disorganized, they are also not able to complete their task, and they lose things. This child also have problem with impulsivity, that is acting without prior thinking. This lead to jumping, risk-taking behavior, and being reckless. This is especially a concern or safety concern which prone them to accident, and sometimes this seems like they are very defiant, but this is related to not thinking or planning. Other than these cardinal symptoms, this child may present with other problems like conduct disorder, and older children like dissocial behavior, autism trait, learning disability, seizure disorder, tic disorder, anxiety disorder, depression, or OCD. If we see the diagnostic criteria, the disturbance, the cardinal symptom which we describe should be present in two settings. An ICD-10, this is called hyperkinetic disorder. The age of onset according to the ICD-10 is in younger children, that is up to 5 years. And in DSM-5, this is called attention deficit hyperactive disorder. In DSM-5, the diagnosis or the diagnostic criteria is more flexible. They include the children up to 12 years of age. For DSM-5, presence of one symptom is enough for the diagnosis of ADHD. But according to the ICD-10, presence of hyperactivity and inattention is necessary. So if we see that the diagnostic criteria in ICD-10 is more restricted, while in diagnostic criteria in DSM-5 is more flexible. If we see the differential diagnosis, this include the conduct disorder, this include the autism spectrum disorder, learning disability, OCD, anxiety, depression, tic disorder, and in older children this also includes the substance use disorder and mania. If we see the epidemiology and causes for ADHD, this is 2 to 5 times in school-going children. This is more common in boys, and the causes are related to genetic factor, that is ADHD runs in families. The environmental factors can be problems during pregnancy, or the circumstances or complication during birth or any other significant trauma in the life can contribute to the development of ADHD. Some of the evidence show that maternal smoking, alcohol use, and lead exposure can also increase the risk of ADHD. If we see the brain of this child, there is something which is called disruptive connectivity. The connection between the different brain areas are not well established. The other finding, which is impairment in the frontal lobe, we see that impairment of dopamine and another chemical that is called noradrenaline. Due to these problems, these childs are hyperactive, inattentive, and they are also impulsive. There are some misconceptions. Some people believe that the ADHD might be due to poor parenting, but evidence does not support this notion. Instead, parenting play a crucial role in helping and managing a child with ADHD. Another notion or stigma or misconception is that food additives lead to ADHD, but this is also not proven by the studies. If we see the management of ADHD, the basic approach is same as we described in autism spectrum disorder, that is the detailed history, examination, mental state examination, biopsychosocial investigation. The psychological investigation which is used for ADHD is Connor's rating scale. There are three versions of Connor's rating scale. One is for parents, one is for teacher, and one is self-reported. If we talk about the treatment of ADHD, the treatment is biopsychosocial. The biological treatment includes the drug, and the drugs which are used for ADHD are divided into two groups. One group is called CNS stimulant, the other is non-CNS stimulant. The stimulant drug include methylphenidate, amphetamine, dexamphetamine, lisdexamfetamine, while the non-stimulant drug include atomoxetine, that is noradrenaline reuptake inhibitor, clonidine, and guanfacine. So, the stimulant medication are first line according to the NICE guideline, especially the methylphenidate. There are some questions by some people that these childs are already hyperactive, how the stimulant medication can help this child. The explanation for this is these child have hyperactivity due to malfunctioning of certain brain areas or a problem with some chemical imbalance like noradrenaline and dopamine in certain brain areas. What these stimulant medication do, improve the chemical imbalance in certain brain areas. Therefore, these medication help the people with ADHD. There's some caution or important thing before starting the stimulant medication we should consider, because these medication in long run decrease the weight, they cause hypertension, and they can causes changes in heart rate. So before starting these medication, a recording of weight, heart rate, and blood pressure should be taken and monitored periodically. Other than that, the other issue with the stimulant is that there's a tendency of misusing these drugs. So if a person is already using any other psychoactive substance, using a stimulant on those patients is something might be alarming. The other issue with stimulant is that These drugs, in some cases, can increase the risk of tic disorder or can worsen the tic, and these medications are also contraindicated in epilepsy. The atomoxetine, that is a non-stimulant medication, is first-line alternative, and it is safer in cases with comorbid tic disorder, comorbid epilepsy, and comorbid substance use. But in some cases, atomoxetine can lead to deranged LFT, so regular monitoring of LFT is necessary when the patient is on atomoxetine. Psychosocial treatment involves parent managing training to improve the parenting skills, behavioral modification program that involves positive reinforcement of the good behavior and negative reinforcement for unwanted or undesirable behaviors. The other psychosocial intervention include teacher training, social skill training, support to parents and teachers. There are some dietary habits that are important in some cases. In some child, the ADHD symptom worsen with certain foods. In those cases, avoiding those food is necessary. And there is some evidence or some studies show that the food preservatives and additives can worsen ADHD. So in those cases, avoiding those preservatives and additives is necessary. What is the prognosis? So 1/3 of sufferers improve with medication and their adult life, they further don't need any medication. But 1/3 need continuous medication use. If the ADHD is not treated, then the risk of substance use, increased rate of juvenile delinquency, increased rate of psychiatric disorders such as depression, anxiety, academic failure, and increased rate of subsequent antisocial behavior. Thank you for listening.